This is Dr. Bill White, and I'm with the American Orthodontic Society, and I want to discuss a video that was made in the University of Lund in Sweden in 1985. It has been one of the best contributions to TMJ work that I've ever seen, and I've used it in lectures for years, at least 30 years, and it is something very good, and I wanted to run over some of it with you here today. And I'm going to start the video, and this apparently is a picture of the university, and there will be the two dentists that I can't pronounce their names, but this is one, and here's another one, and that's the University of Lund, and apparently this was done in 1985. And here are the two dentists, and they're going to be discussing how the TMJ works, and they did this cut down on these people, the corpses that had been really something very precious. Now, this is a jaw joint. This is the condyle right here that I'm circling, and the jaw would be out to my right, out over here, and this is the fossa. Now I'm going to draw it with this deal. It's the fossa in here. Now this is what we call the disc, and it is a biconcave muscle structure made out of dense connective tissue. It's not just regular cartilage. And this area back in here is the area of the retrodiscal tissue, and synovial fluid is secreted out of this into the upper joint space and into the lower joint space. Now this tissue right in this area is so tough that when you bite on your teeth out in the front of your mouth, it's way off to the right out here, and the muscle structure is close to the joint. And so if you bite with 10 pounds of force on your front teeth, it might be 25 or 30 pounds of force on the joints back here in the back. And so this tissue right in here in the joint, in this disc, takes so much pressure. There are no nerve endings in this part right here, and there are no blood vessels here. So this material in this part is depending on the synovial fluid, which is formed back here in the retrodiscal tissue. And this synovial fluid is a highly refined plasma from the blood, but has food particles in it, and it goes out into the upper joint space and also the lower joint space. In other words, it's secreted here and up in here into the upper joint space. And when you close your teeth together, this just lightly, it does it good. It pushes this synovial fluid down into the disc tissue and feeds it and takes care of it. And it also takes out the impurities here, and this portion of it is taken back into the retrodiscal tissue and is purified and sent back into the bloodstream, and this works kind of like kidneys in this area. Now I'm going to erase that and go back here and erase that. I want to show you the actual thing in just a minute. They'll show a healthy joint, and I want to discuss some of this again. And one of the doctors is pointing out this on the video. If you have not heard this video or seen it, I would advise trying to purchase one or get it and look at it many times. And it is a cut down on these cadavers that are awful fresh and able to do. Now, when we get into the cut downs, it'll be more meaningful to you because you can see the actual movement of the jaw joint, the condyle moving forward in here. Okay, here is a normal, healthy joint. And this is the upper joint space, and this is the lower joint space. And if they close together, you will notice that the condyle does not go all the way up into this space up here. Let me stop this in a minute, and we'll see what we can do here. Now the condyle stopped down in this portion. This portion right up here now, and this behind is the retrodiscal tissue. And if you haven't looked at that, go on your computer to retrodiscal tissue and read about it. And this synovial fluid, which is the slickest stuff known to man, we can't reproduce something that good, is formed in this area. And there's a lot of blood vessels and nerves in this area. And what, to me, I've worked on people with TMJ problems for about 30 years. And I worked with a guy who did nothing but that, and he sent them to me to straighten their teeth up and fix their teeth where they would close in a normal jaw relationship where the jaw was not having to go to a position that was not comfortable to it. And that was a distal slide. Now, I hunted all my life, all the practice, when I got interested in TMJ work and orthodontics, for somebody that had a forward slide. Now, if you can look at my teeth right here, if I bit together and I had a forward slide, I would slide my jaw forward when I went to close. In other words, I'd close somewhere here and then it'd go this way. Now, people with a distal slide, they get there, they close, and their teeth are here, and then they go back further. Now, when they go back, when they back up their front teeth, it pushes the condyle back and presses on the retrodiscal tissue. Now, some people can have that happen in this room back in here, and they don't really crowd the retrodiscal tissue like other people do. But some people, if you do something that causes the jaw to go back when you close, then it shoves this condyle back into this retrodiscal tissue and impinges on the blood supply and the nerves in here, and it cannot produce the synovial fluid like it should, and it can't go out here and feed this disc that's in between the condyle and the fossa out here. And then this gets inflamed. But most everybody that I ran into with a TMJ problem, if you put your finger right in front of their ear, right up in here, and have them open and close kind of slow, and put your finger on the back side of the condyle, which would be back in here, people with this irritated tissue right here will be inflamed and sore. They won't even let you touch the area where it is. It'll be so sore they can't do it. Now, I've got one that got damaged a few years ago, and when it gets inflamed, I can't put my finger up there and press into it. And so The vast majority of people with the TMJ problem get relief when you move the jaw forward. And so we would find out where their jaw closed comfortably, and we would mark it on their teeth. I'd just take a little marking pencil and mark it. I never used any of these fancy machines that tell you where the jaw closes. I would mark it. And if the teeth fit right here, then, that's where their jaw wanted to close, then that's where we would build a splint and then put a ramp on it that made the jaw close there, and you give them this splint, and 90% of the people would get over the pain. And we were able to get rid of the pain from all of these people. Now, that sounds like a smart aleck, but that was true. And what you're worrying with is the pressure that you put on this retrodiscal tissue, driving the mandible back. And you can do it sleeping on with your hand on your chin, or just getting hit in the mouth, or just having your teeth being shoved back by the deep bite. And a lot of people's mouth, their jaw grows forward as they get a little older, and that forward growth, if the bite is closed, then that puts pressure on the whole lower arch, and the condyle gets pushed back, and it presses down on this retrodiscal tissue back here. Go on your computer and look for retrodiscal tissue and read about the stuff. It's extremely complicated how this works. It's like a set of kidneys back here. It brings the food out here to this tissue that doesn't, it's under so much pressure that the tissue has no blood vessels and no arteries in here, no nerve endings, and yet it has to get fed, and is fed by this synovial fluid that's formed in the retrodiscal tissue. And if you put pressure on that and squeeze it where the blood supply is not working properly, then you will have trouble with it out here. Now, let's watch this go for another time or two. Now, this is a normal one. You see the condyle. Now, the jaw is out in this, to my right. I can't draw on this now. It's out to the right. In fact, I did draw on it, and it caused it to stop. Okay. Now, it goes back, but it doesn't squeeze up there all the way. Now, here is a disc, superior position of the disc. And now this disc looks like it has actually worn out. This portion right here, there's a hole in this disc. Now this disc may have been damaged, and we used to, when people broke their jaw, we would wire the jaws together and keep them still for several weeks while the bone healed. But during that period of time, the synovial fluid couldn't get to this tissue in here. The tissue in the disc itself died, actually. And I've talked to old surgeons that operated on people like this, and they said they could go in and scrape across the disc, and it was like cheese. It was just dead tissue. But there's no nerve endings in there, so it didn't hurt, it didn't bother them, but the tissue was actually dead in there. And so this would disintegrate. Now, I'm 91 and a half, I'll be 92 my next birthday, and my discs are still in good shape. I open and close mouth, and I don't hear any dragging or anything else. So this tissue has lasted for 90-something years, and it shows no breaking down at this point. So I'm sure that if this person's disc broke down from just old age or something, he or she had to be mighty old at this point. Very difficult. Now this joint is functioning okay, but the disc itself appears to have a hole in the middle of it. In other words, it's worn out in there, so the bone structure would have to be rubbing against each other right in this area, and I think there's a hole in the middle of that disc. Let's continue with this, and let me see. I'll make it move again. If you haven't watched this, these videos for many times and try to understand what's going on in the jaw joint. Now this joint appears to have the disc with a hole in it, or it's awful thin in this area, and the distal part of it is almost separated from the mesial part. Now when people get hit in the mouth, it drives the condyle back to the distal. Now the jaw's out to the left right now, the teeth would be out there, and this is opening the jaw real wide, and I don't see it. It's not being pulled down to show that separation. Now these two dentists in Sweden did a real contribution to dentistry and to TMJ work. It has helped me through the years, and I've helped many other people and gotten them out of pain simply knowing some of the, you see this space. So that disc had a hole in the middle of it, but at least had edges around it and was staying on, so it wasn't popping or clicking as it functioned. And so we'll go ahead and they'll show another case that they reduced, and you see when it goes up here, that's not pushing this bone up against that completely, so there's room for synovial fluid to have formed here. So apparently this case had pretty good synovial fluid and was functioning from that standpoint. Now I don't know whether it got starved for a period of time and weakened the joint or the tissue in here. It's dense connective tissue, but has no nerves in it and no blood vessels in this area, and is fed by the synovial fluid. And when somebody has a bad TMJ problem, well, there it is. They opened it up and you can see the hole in it. It's on the mesial side, and the buccal side here has been cut away. But this disc is sitting here. Now we're looking at the upper joint space. Now here is a joint, where the disc itself is sliding off out of position. It's sliding in the front, and it gets out in front of the condyle. Now as you go to open and it pops back up here, you'll have somebody that opens and it'll go, or you can hear a little snap as the condyle goes back up on top, and if you listen carefully you can hear it slide off the disc, and now as they open again it'll click. Now people that have one side like that, they will open their mouth kind of to the side, and then they'll go, and then they'll bring their jaw back to the center, their jaw one side. It keeps it from opening over there. Or if somebody has both joints are bad and they can't get the condyle over the disc, their mouth will be locked, and they can only open a few millimeters, maybe half of the distance they'll be able to open later on. So this person right here has a disc that pops off when they close and pops back on when they open. The closure slipping down does not click much. If you listen close or watch their jaw, you can see it. And some people, it'll click on one side early and then click on the other side later, and they open all the way. I had one lady once that only opened to the one side, so one joint was stuck and couldn't get past. Now this is a displacement with reduction. Now that's, if we watch this side, this disc right in here, now the jaw will be out to the left this side. And this is the upper joint space, and this is the lower joint space, and this is where the synovial fluid is formed, and it secretes through the tissue into here and into this part, and then the upper joint space feeds the upper part of the disc, and the lower joint space feeds the lower part, and it's separated. That's not together normally unless you got the disc is worn out in here, like the previous slide showed there. And this is moving pretty slow, so I'm taking up 25 minutes here explaining this. I think I'm going to come back and do a video on the latter part of this, and I'll go ahead and close this video out. And I thank you for watching, and I hope that you'll subscribe to our channel. And if you can learn about this and how to keep from pushing the jaw backwards, that relieves most of these cases. And I have never found anybody whose jaw slid forward. I'm sure there are people that can do that. There's arthritis and trauma and things like that. But just to slide forward, it does not hurt it keeps the condyle from even putting pressure on this. In other words, they go to bite, the condyle will slide out here. It doesn't ever put any pressure on the retrodiscal tissue, and so that stays healthy. And that's what I found. I'm sure there's somebody with that problem, but I found nobody with TMJ problems that hadn't been molested that had a forward slide. So I'm going to close out now and close this video, and thank you for watching, and I'm going to close it.